He says it's too loud. Is that better? Okay, my voice travels without a microphone, so I try to be aware of that. Is that better? Okay, thank you. I'm Leanne Bailey Clayton. I'm the Director of Health Services and the Licensed Nursing Home Administrator here at the Forest. I have been here, I'm in my 26th year. I'm in my 26th year here at the Forest. And today we are here to talk about transitions through the continuum. This is the third part of a four-part series that we began last winter, and we will be repeating this series. This is an opportunity for you to invite your family, your friends, anyone that is significant to you in your particular life that may be a part of healthcare decisions for you or work with you with finances or anything like that, so we can make sure that you're aware and that we're able to be helpful to you and your family. And this is, when there's a crisis, it's not the first time you see us or meet us. You can put a name and a face together, because our responsibility here for you is to be that continuum of care that you need while you're here at the Forest at Duke. So we will begin today, and just a couple of things. If we could please hold all questions to the end. We will be passing around, Aja will be bringing around a microphone for questions, and if you have a specific person you'd like to answer that question, please let us know that. We will repeat the question as we are recording today for this to be on Cubigo. And we just want to make sure that anyone that's watching later for the recording does hear the question clearly. Please know, just a little ground rule, is we cannot entertain specific questions about specific health conditions for specific people, okay? We cannot do that. We are happy to answer any general questions that we can, but you know all the rules, rules of engagement in terms of not being able to, divulge or talk about specific health conditions for people. But we thank you for being here, and now our esteemed panel will introduce themselves, and we're just grateful that they're here with us today and that you are, and I appreciate you all being here.
Good afternoon. It's good to see you all today. I am Dr. Milta Little. I am one of the attending physicians and the medical director here at the Forest, and I've been here almost 6 years now. So still, compared to a lot of the people who work here, a newbie, but gotten to know the lay of the land quite a bit at this point.
My name is Gwen Boer. I am hello? Can you hear? Oh, you have to hold it very close. Okay. Gwendolyn Boer. I am a physician here. I work as an attending physician in the clinic. I'm also the clinic director and in the assisted living and health center part.
I'm Holly Winger. I'm a nurse practitioner. I've been at the Forest about 7 years, and I work in the clinic and in the health center in conjunction with Dr. Little and Dr. Boer.
Hello, I'm April Ravelli, Director of Sales and Marketing here with the Forest, and I have been here for 8 years.
And I forgot to say I've been here for 20 years.
Thank you, Dr. Boer. Good afternoon. My name is Jennifer King. I am one of the social workers. I work with residents A through K. I've been at the Forest for 3 years.
And I'm Carissa Campbell. I'm the other half of the alphabet, L through Z, and I've been here for just over 3 years.
Okay, April, if you will, please talk with us a little bit about the contract, when you come to the Forest, what you sign up for. What does that mean to someone in terms of transitions throughout the continuum?
Yeah, great, thank you. So as if I'm seeing a lot of faces here that have sat in webinars with me, I refer to our contract as that promise that we make to care for you for your lifetime. And so, of course, the Residence and Care Agreement, which is the contract that you sign with the Forest at Duke, does cover transitions. So it talks through the different levels of care here at the Forest and how those changes in care might happen. The Forest at Duke is what's known as a Type B, or a modified contract, which means that when you join the community, you pay a little bit larger of an entry fee. And then a portion of that is actually prepaid medical, so that when you access those higher levels of care, you do so at a discount. Additionally, portions of your monthly fee are also considered prepaying medical, and so you can put both of those on your taxes, both the entry fee and the monthly fee. So with the Type B community, most folks join us in independent living, and then should you need a higher level of care, either temporarily or permanent, you access that through the continuum. We are not what someone would call an age-in-place community. That's not how a Type B community works. We really rely on that continuum of care. So when you make that plan for the Forest, you are making a plan for the rest of your lifetime.
So now Jennifer King will talk with us a bit about the types of home care services that are available to resource for you at the Forest at Duke and from agencies within our communities at large.
Okay. So in talking about home care services, this is just one area of support to help maintain safety in an independent living cottage or apartment. It is not a level of care. Home care is supplemental to living independently. So residents may have up to 4 hours daily of hands-on care. And what that looks like is someone may need help with bathing or dressing, helping get in and out of bed in the evening or in the morning. Those are the types of things that we say are hands-on, and that's where we go with our 4 hours a day. There are specific exceptions to 4 hours a day. If someone may be coming back from the hospital or other things, we do take that on a case-by-case basis. We do not include any type of companionship in that. So some people may have companions or people who come in and help them pay their bills, or people who come and do some light housekeeping or just visiting, or help do laundry. Those types of things are not included in those 4 hours. We're really focused on hands-on care. Our social workers, yes, of course, we do have the Forest at Home here, but we also have a list of outside providers who have been vetted by the Forest. We know that these home care agencies do the same type of background checks and drug tests and all the things that we do here, that they're insured, that they are licensed home care agencies. And then if someone is interested in having someone as a private duty, a single person who is not part of a home care agency, they would have to complete paperwork and some background information before that person would be able to come and work with them here on campus. And Carissa and I both have the checklist for that, and so residents will reach out to us and ask those questions, and we can provide them with the checklist so that they can go ahead and move forward. But again, before anybody can come here as a private duty provider, you really need to make sure you have all that paperwork back. And that paperwork, Leanne, would go to... Okay, yes, it resides in a file with home care for us to be able to make sure we have something to look at in case there's any questions.
Okay, so I'd like to talk a little bit about the Health Maintenance Committee that has been in existence since the beginning of the Forest at Duke. And that is the committee in which we have no way of keeping up with the 400 of you. There's just no way to do that. So we have to have a way in which we are able to know if someone is having a change that maybe we can impact in such a way that it just turns things around and you continue to be in your independent living for, as long as you absolutely want to be. So that health maintenance committee is made up of an administration, a medical provider, social work, therapy, clinic, and other departmental representation as needed. The communication is with the resident first. That is done by the social workers. And then the responsible parties will become involved should for some reason you are not able to, or you have some type of cognitive decline and are unable to understand the process that we're trying to go through with you. But we want to bring your healthcare power of attorney along in the process if there is a need or a consideration for you needing maybe a temporary stay in the health center, or you needing to have some home care in your home, or the opportunity for you to begin to look at, say, an assisted living level of care change. We specifically have a continuum with caregivers here with our social workers and our physicians very purposefully. If you are in the alphabet A through K and you are working with Jennifer King, you having a relationship with Jennifer King ahead of time, or Carissa in her alphabet, it's best that you know that person for as long as possible. They need to have a relationship with you. You need to have a relationship with them. And the very best situation is they've gotten to know your family too along the way. So when that time comes, we keep as much, there's no intention to have any surprise element on our part. There certainly are acute things that can happen, and we have to, of course, ensure your safety at that point. However, our intention is always for you to feel informed along the path as things are changing. None of us are getting younger, and as time goes on, things do change. It can be as one-dimensional as you've had all of your children have moved out of the local area and your support system has changed. That's something that Carissa and Jennifer certainly would openly talk with you about and look at what other support could be for you in the area. So, or it could be something as dramatic as you've fallen, you've fractured a bone, you need to be in the health center for a short rehab stay, and the social worker will be working with you. They're getting to know you. The other piece of that really important continuity is your physicians. If you have a physician here at the Forest at Duke, Dr. Little, Holly, Dr. Boer, they are your primary care. They will follow you in the health center. They already know you. You already have a relationship with them. So that is a very important part of the continuum. If you are in the health center and you have a different physician, you will have one of these primary care providers for your time in the health center. So there are many different ways that you can become in relationship with the providers and the social workers during your time here at the Forest that is not necessarily focused on you're moving to the health center. So I just wanted to make you aware of that. We have the ability to speak with your physician if it's not one of our Forest physicians. The physicians have an opportunity to talk with them through, of course, telephone. They can talk with them through Epic in terms of those types of communication. So we want your physician to stay informed about what's going on with you in the situation that maybe you're not using a physician here at the Forest. So I just wanted to make those continuity things really focused and emphasized for you because that is the way that we're doing. It's a hard time when you transition. I mean, I've probably had a dozen people jump up and say, oh yes, Leanne, I want to come to the health center now. Let me go pick a room. That's sort of not how that happens. But there are people that say, I don't want to downsize ever again. I'd like to go ahead and move. But there typically something has changed. Okay, something has changed in the time that you're here, and that can have its own emotional impact on you. So we try very hard to have as many parts of your team as continuity as possible. So the Health Maintenance Committee is formed and has been formulated so that if someone has a respond call, if someone has been to the hospital and now has gone home, if someone has had a change in their condition, and the physician felt like maybe they needed a visit from the social worker for some additional support or resources. This is what the Health Maintenance Committee is comprised of, and I just want to clear up, it is not a hit list. It is not a list that we're going to come in the middle of the night and get you to go to the health center. It's nothing like that. This is a way for us to responsibly follow along of things that are changing with you, so that we're there to help you before you think that you need us, okay? That's part of our commitment to you, is to head off as many things as possible and keep the complications down to a minimum, because it's a difficult time. So we do meet weekly. People come on the list, people go off the list, and that is basically, it's an ebb and flow in terms of what's going on with you. When someone discharges home from a temporary stay, then we're going to follow them for a while. The social workers are going to follow them. They're going to follow up in the clinic or with their physicians. So we make sure we don't miss anything. Getting home from the hospital, once you've gone to the hospital and the health center, when you get home, you're tired. You need to go home and rest. But we want to make sure that we're continuing to make sure you're having your therapy services and meal delivery if necessary. So we're keeping up with you in such a way that we are being as helpful as possible. Should there be a time that there is a final recommendation made that someone needs to move to the health center, that is something that the social workers will be communicating with you. They will talk with you about that, and our goal is always to make that something that's not really a surprise to you. It's something that has been formulated throughout your stay here, knowing that, my mobility's changing, my cognition's changing, all of that. We hope our system has worked in such a way that this has been an ongoing relationship, and you know that you and that social worker and this interdisciplinary team and your physician are going to move through this process. Let me remind you, that's a difficult time. It's a very difficult time, but those things that can be easier, we try very hard to take care of. So should, for instance, you not be in agreement with what the recommendation is at the Forest at Duke for your level of care, we will have ongoing conversations about that, but we can certainly have your physician attend the meeting with us, your specific physician. The social workers will certainly talk with your primary care. If they happen to not be here at the Forest, they will communicate with them. And then certainly if we need to talk further about that and have Dr. Little become involved as the medical director here. The thing we don't like to do, but we have to do sometimes, is remind people of their contract that April was referring to. And what your contract does for you here in terms of supporting you is, you say in that contract, there may be a time, this is not a quote, there may be a time I'm not particularly objective about what level of care I need. Things may have changed for me, and I'm not the best person to make that decision, but by golly, I want to stay in my apartment. What we're responsible for doing and what we are committed to doing is remaining very objective about that. We look at safety. We look at medication administration. We look at mobility. We look at the ability to, insight and judgment. Can someone get out if there's a fire alarm? Those types of things. There's not a checklist, okay? I want to be clear, there's no checklist. There's no penalty if something happens. There's no foul. None of those things are, I've heard all those things in my 26 years. There are none of those things. If you've done one transition here, you've done one, okay? If the social workers have worked with one person in a transition and the physicians have and the interdisciplinary team have, they've only worked with one, because they're all different. Every single one of them are different. And know that as our customer, that is very important to us. We want it to be singular. That's very important. So I just wanted to share that information with you. And then I wanted, oh, is there? I'm sorry. This one? Okay. Oh, yes, okay. I could talk to this for like 12 years. So the Forest at Duke, in our health center, we do have 90 beds total. 58 of those are skilled nursing, 4 of those are Medicare certified, and we have 32 assisted living level care beds, and 10 of those are memory care. So please know that our Medicare beds are strictly for our residents that are enrolled in contract, whether you live in this community or you're one of our early acceptance program members, then you in fact have access to those beds. You work with Jessica Hackett, our resident navigator, who works with you at the hospital in navigating and negotiating, if you will, the ins and outs of Medicare, Medicare Advantage, and insurance companies where that's concerned. So we just wanted you to know what that makeup was.
You ready for the next?
Mm-hmm. Okay, all right. There'll be another speaker in a minute, I'm sorry. What we want to talk about a little bit is what different types of admissions look like in the health center. We want to look at a health center stay. It's an acute situation, but you have not had a hospital stay. So let's just say you went and had some outpatient procedure. It was all simple. You came back home. Your leg is hot and red, and you know that's not good. You push your respond pendant, the nurse comes and sees it, and our docs say, you need to have some fairly hardcore antibiotics. That's probably not a clinical term, but antibiotics, and we need to monitor you for this, okay? So you would be able to come to the health center. You would not qualify for a Medicare stay because you have not been in 3 overnights at the hospital, and you would stay in what is considered one of our temporary stay beds in the skilled nursing facility on 3 South. There you would utilize your prepaid days. So if you are a resident in independent living or if you are an EAP member, you have 15 prepaid days, and please correct me, panel, if I say something wrong, 15 prepaid days that you are entitled to for care in the health center. And should you be a resident that is there for 3 days and leaves for 3 months, for every month you're out of the health center, you rejuvenate one of those days back up to 15 days. Did I say that right? Okay. Please don't worry about keeping up with that. We keep up with that for you, and Jessica will certainly communicate that with you when she's talking with you about that. Okay? So that's one scenario. The second scenario is you have come to the health center because you had an acute condition, and let's just say you fractured your hip, and you have gone to the hospital for a qualifying 3 midnight stay where you were technically admitted, and there's the difference in a traditional Medicare stay and a Medicare Advantage stay. Both of those require you to be in a Medicare bed. Traditional Medicare allows for nursing and therapy to be the drivers of your length of stay, okay? So I'll go ahead and get rid of the first myth. You don't automatically get 100 days of coverage. That's not correct. The best way to understand that is typically, as long as you're meeting the criteria for meeting your goals with therapy, continuing to progress with nursing toward what it's going to take for you to manage yourself at home, then you are continuing to qualify for that coverage. That may be 20 days, that may be 32 days, that may be 41 days. It's all about you making the progress you need. When you plateau, then traditional Medicare says, we need to have been making a discharge plan all along, which we do that, and you're ready to go home and have some outpatient rehab at home, okay? So your insurance sort of follows you through. It followed you to the hospital. It followed you to the nursing facility. It's gonna follow you home, and it's following you along that way. Where the Medicare Advantage plans are concerned, they're a bit different. The Medicare Advantage plans require a pre-authorization before you come to the facility. The hospital is responsible for getting those pre-authorizations, which Jessica's very happy about, that is done that way. It didn't used to be that way. And it is a very specific pre-approval period of time that they give you. So I'm just gonna start out this way. We have pre-approved you, I'm Humana, I've pre-approved Ms. Smith for 10 days, okay? Well, they're gonna tell us what day we're sending more records to show your progress. So you may or may not be extended past that 10 days. Again, we're keeping you informed of this all along the way, okay? The scary part is that you try to keep up with all this. It's a lot, and so we keep you involved with this. We keep you and whatever family member or responsible party you have said you want us to talk to, we will keep you in the loop on that. The Medicare Advantage plans are very, they're not futuristic in what their goals look like. They're very short-term goals, the next short-term time, next short-term time. So they're very different in terms of the way they interact with you in terms of your coverage. We're at the helm of that. We're making sure we're getting good information. We're sending them the records. Should we get to a point that you need to appeal a decision, Jessica and the social worker will walk you through that and how that needs to happen. If your responsible party needs to do something like that for you because that's not something you can manage at that point, then we will work with them as well, okay? So, I have another one, don't I? Okay, so health center, acute stay, temporary to permanent stay. So someone comes to the health center, let's say that same person broke that same hip, and they come to the health center. They have gone through the Medicare rehab program in the health center. They're not quite comfortable with going home yet, and so they want to use a few of their prepaid days to be in the temporary status. But please know our responsibility is to evaluate your progress to return home the whole time. We're always told the discharge plan starts on the day of admission, okay? Because we don't want people to feel surprised. So it's very important to know that the therapists are working toward goals with you. The social workers are working through goals with you. Nursing's working through goals with you. The physicians are setting up goals for you. And all of those things may turn out that returning to home is not safe for you. That's not going to be what is accomplished for you. That is going to be the next step. So that is, again, not something we wait to the last minute to talk about. We don't try to talk about it prematurely, but if all the red flags are there that returning to home is not going to be what is successful and safe for you, then we'll begin to have those conversations with you. You'll be in conversation with your physician, you'll be in conversation with your social worker, the rehab team, the nursing team. All of those people are rallying around you to say, hey, let's see how we can make this work for you the best way. So I think Carissa's next.
Sorry. So our next scenario is someone living in independent living who has a gradual physical decline, and kind of what leads us to make the recommendation for a transition to the health center. So like Leanne said earlier, nothing's cookie cutter. I wouldn't say, you know what, Jennifer, I've been keeping tabs on you. You've got 8 points this quarter because you've been to the hospital twice, you've had 2 respond calls, and 2 acute visits in the clinic. Everything is very individualistic. It depends on what resources are in place. What are residents, open to having in their home? Some residents are not open to having someone from home care come by. It makes them uncomfortable. So we kind of have to look at this holistic picture of, we do have to take into account, is someone unable to transfer on their own independently if they live by themselves, which is leading to falls? Are we seeing wounds when the residents goes to the clinic because they're not able to provide their continence care and get themselves clean? So we're seeing skin breakdown. May bring up to Jennifer that we may need to start talking about a move to the health center, and her friend Jessica comes to me and says, she's fine, look at her. She hasn't had any changes. She's still with it cognitively. I don't know why you're bullying Jennifer, but I could say, well, I hear you, you're her advocate, but I know that it took Jennifer 3 hours to get ready this morning, and her apartment used to be pristine, and now sometimes she sleeps in her bed without bed sheets because she's not able to physically get those on. So we always have to investigate and put resources into place. And those resources being home care, therapy, and those folks, along with the providers, look at how would Jennifer function in an emergency if she's not physically able to get out of her bed easily, and it would take her a long time. If Jennifer's vision or hearing is declining, to the point where we worry that she may not be able to get out in the event of a fire or hear an alarm if there's an emergency. What are we going to do in that instance? We can certainly utilize the health center as a permanent transition as a hub of care. So Jennifer can be with us in the morning. We can assist her getting up, getting ready for her day, and she may spend the majority of her day over in independent living, doing her book clubs and going to socials. But we know at the end of the day at the health center, we're going to make sure that she's getting the physical assistance that she needs to maintain her dignity and prolong the best we can eventual further decline. And Jennifer and I, and as Leanne said, we recognize this is hard. I've had staff members coming up to me before and say, why haven't you moved Jessica yet? Well, we realize that we're people working with people. This is a delicate situation. Some residents may have more family support than others. How do we come up with, positive approaches to provide services for that resident with what we have? So.
Okay. For some reason, Carissa always uses me as her example. It did take me 3 hours to get ready this morning, maybe an hour. So the final one that we have is when a resident has a gradual cognitive decline. So I'm going to use Carissa. So say Carissa has been doing well, but we start noticing that she's being a little bit more forgetful, maybe attending things later than normal, doesn't seem like she's on top of her schedule like she used to, forgetting appointments, those types of things. So she goes to the clinic to see one of her providers, and that provider does some testing, and we find out diagnosis of mild cognitive impairment. So does that mean that it's time for her to move to the health center? Not necessarily. That's a starting point. So normally, as a social worker, one of us, I would get involved with Carissa and talk with her a little bit about what her needs are at the present time. She may not have anything right now, or she may need a little bit more support. So here are some things to take into consideration. First thing, what we call the higher level ADLs, paying bills, managing finances, doing taxes, those types of things. Driving, is Carissa still able to drive her car safely, whether it's on campus or off campus? Has she gone places and forgotten where she was and knows that she lives at the Forest, so she asks some nice person at the gas station to call the Forest and get some directions on how to get back here? Should that person be driving? I don't think so. The other things are with medications. Is Carissa still able to manage her medications? What kind of interventions do we possibly need for that? Well, we have therapy, so here's an intervention. Let's get speech therapy involved. Speech therapy not only works on speech, but also cognition and swallowing. With cognition, they may be able to put in some external memory cues to help Carissa do a little bit better about utilizing technology to remind her to take her medicines. Or maybe we work through our clinic and work with a local pharmacy that can do pill packs. That way the person doesn't have to take on the task of, or the energy, cognitive energy, of the task of having to put their medicines in a medicine box or remembering if they've already taken, pills out of the pill bottle, those types of things. Some people have systems set up that they can continue to utilize throughout their stay in independent living. Other people may need more support. Occupational therapy may get involved. Occupational therapy is looking at the home. Is this person safe to remain in their home? Are they able to react in certain situations? There have been times when we've asked the question to residents through the home safety assessment, how would you react in the event of an emergency? What if you fell? The resident's wearing their pendant, but at no time do they say, I would push my pendant. They said they would just lay there and yell help until someone came along and heard them. That person may not be able to continue to remain independent because of safety reasons. So throughout the time of working with someone who has mild cognitive impairment, through the transition into whether it be dementia or the type of dementia they have, we're there through the process of helping look at interventions. Well, I do really, really good throughout the day, but sometimes I'm not always good about taking my medicine. I'm horrible at technology, so setting up an Alexa or setting up some other reminder would be difficult for me. Well, there's options. There's home care services that can provide medication queuing to make sure someone's taking them if that's the only situation that is currently a problem. If someone is concerned about driving, our medical team or the person's primary care provider would be involved in talking about and assessing driving in terms of setting up appointments to have a driving evaluation. There are local occupational therapists who will actually do a simulated driving test, and then they can give their pointers in terms of should you be driving or not be driving. Carissa may go and not even pass the first hour of the written part, or she may do well there, but when she gets to the simulation, she is not making good choices in terms of her reaction time and those things to show that she should no longer be driving. It's helpful if the person makes that decision themselves, but it's a hard decision because that's an independent function. I've only ever had one resident in my career come up to me and say, Jennifer, guess what? I graduated from driving. My husband's gonna drive me around everywhere I go now. Because she noticed, and her family noticed, that her memory was declining to the point where it wasn't safe for her to be behind the wheel. And she embraced that. Most people don't embrace it, and it's a very difficult conversation to have. So through the different interventions that we try to put in place, we work with the resident and we ask, is it okay to have your family involved? Because this is probably a good time to get your family involved, regardless of where they live, to have a conversation of this is what we're seeing, and this is where they're at right now, and these are things that we're recommending. Some people will be like, well, I'll just get the 4 hours of home care. Well, if you have a cognitive decline, what are you gonna do the other 20 hours? Who's gonna be there to support you those other 20 hours? So whereas in some physical decline, you may be able to get more hands-on care, when it comes to cognitive decline, it's a different situation. But again, as we were saying, should never be a surprise. Unless it's an emergency, it should never be a surprise if it's time for someone to transition from independent living to assisted living or skilled nursing. We do our best to make sure that we're in communication with residents. We work closely with our medical team. We try to reach out to other people, the residents who don't have primary care here, to the physicians of the other residents, with the residents' knowledge that we are reaching out to that physician. Some people are willing to work with us. Some people are not always willing to work with us. But the other thing that I think is also important is that Carissa and I have worked a lot with couples. And so if there are couples where one person is sort of the caregiver or overseeing things, we have notes in terms of if something happens with that person who is the caregiver, this is what needs to happen with their loved one. Whether that be a 24-hour check-in because they might need a little support or some home care or things like that, or meal delivery, or does that person need direct intervention and needs to come to the health center until their caregiver is back, on their feet and being able to provide direct care. And we share that information with the health maintenance committee. We share it with whoever the manager on duty is going to be for the weekend. So if it's off hours or a weekend, there's that continuity of that we know these are the people who may need support immediately if something happens with their spouse or partner. Is there anything to add? Okay. And
Leanne, if you want to go ahead and wrap up.
So I did want to mention the circumstance under which hospice may become involved with a resident at the Forest at Duke and independent living. We do have 2 hospice agencies that we are in contract with. One is Duke Hospice and one is Transitions Hospice. And should someone be in a circumstance in their home where they have become involved with hospice and their passing seems clinically imminent, that person would have the opportunity and would need to have, if they were not coming to the health center and it's deemed safe to be at home, they would need to have 24-hour care with them in their home, because there will need to be someone there to administer their medications. If, in fact, that did not turn out to be a particularly safe or successful scenario, then that would never preclude you from coming to the health center, because we would have hospice just come right over with you and be in consult with us in terms of your care. So that is sort of our presentation. That's our presentation. And so we're going to field some questions now. I was just going to bring the microphone around. Anyone on the panel is more than happy to answer a question, or someone here may be more prepared to answer your question. But if it's all right, we will repeat the question, and then, do y'all have just that one mic you're working with? This one right here? Okay. So we will pass that mic down. I will be in charge of repeating the questions, but I can certainly share this with you guys. And questions?
Is Duke associated, Duke Hospital, with you people?
So the Forest at Duke is in partnership with the Division of Geriatrics at Duke Hospital, and being in contract with our physician makes us a community partner with them. So that is our connection in terms of formally with Duke Hospital.
One other thing, they would have access to Duke MyChart?
So the question is, how are we affiliated with Duke Hospital, or if we are affiliated with Duke Hospital, and do we have access to Duke MyChart? The answer to that question is yes, our physicians do have access to Duke MyChart. Dr. Little, would you like to expound on that a little bit?
Yeah, so the 3 of us and our other attending physician, Dr. Hanau, are all Duke providers. So we are, I was going to say owned by Duke. We aren't owned. We're employed by Duke, and we're contracted with the Forest to provide the medical services. Sometimes I do feel like I'm owned by Duke. And so when we are doing our charting across the campus, whether that's in clinic or in the health center, we are writing our notes in Epic. And so then those notes are then available to you all through MyChart. And so we can communicate with our patients and our residents through MyChart, as well as anybody who is serving as your proxy. We also have direct communication that way through the specialists and other providers. If somebody has an outside primary care provider at either Duke or UNC, we also have pretty direct communications that way as well. At the clinic, we use the Duke Labs. So if you are getting a lab service, whether that's a viral panel, viral respiratory panel, lab draw, those things will get picked up by Duke, run by Duke Labs, and will automatically pop up in your MyChart as well. Mm-hmm.
Next question.
Hi, what is Epic?
Thank you for asking that. The question is, what is Epic? So Epic is the electronic health record that most institutions in the area will use, and there is a lot of communication within our surrounding health centers using that electronic health record. Yeah, so the Epic electronic health record has a variety of ways that it will communicate. Sometimes it's just a kind of a read-only access. We sort of, and a lot of times you have to give permission for us to be able to access that. With UNC and Duke, it's a little bit more seamless and streamlined in that it is a little bit more automatic. So we can usually automatically see the notes and completed things over at UNC. It is not so automatic that we can see everything. And so there is a little bit of some of the communication may be done through different portals in the system to communicate, but we can see quite a bit, and so there's a little bit more of that communication. But it's still done through what's called their Care Everywhere platform, which is the connection between the different electronic health records of Epic.
Great question, thank you. Next question, Kathleen?
Tell me the extent to which your hands-on nursing personnel in the health center have been educated in modern-day accepted hospice care. And you
Yes.
know what I'm asking about.
I do.
It's the classic line, oh, it's too soon to give that dose of pain medicine.
You want to answer that? Or you want me to answer that? Dr. Boyer, you want to answer that? Holly? I mean, I can speak to the nursing piece. Okay. So the question is, to what degree, I think, do the nurses have hands-on experience with intervening with someone that's on hospice in terms of initiating medications for, like a comfort kit, morphine, Ativan, those things about agitation, pain that are in those types of kits? Well, I will say that it's the nurse. Yes, they have education and exposure to this. It's the nurse's job to assess. It's the nurse's job to understand the resident's wishes. It's the physician's job to make sure that those medications are ordered. Hospice is aware of what's going on. And we work with hospice every day. They are consultant with us, and we look to them. Our physicians look to them, our nurses look to them, our social workers look to them, families, residents, all look to them for that. But we also know that our primary responsibility is to make sure that resident has what they need. We're not waiting on a call from hospice to make sure that a resident has what they need. Our geriatricians are highly qualified and educated in making those decisions, and someone's comfort is of the utmost concern. Anybody want to add to that?
Does that answer your question?
So Kathleen's asked this like 20 times. We talk about this a lot. Yeah, and that's okay. I'll keep answering.
Yes, I'd like to ask a question about the increasing number of independent living residents that will happen very shortly. How is your team sized in terms of reach or extension to care for the additional residents? Do you see an increase in the number? And if so, in what areas? For example, there are 2 independent social workers now. Will that number need to increase in order to provide meaningful and adequate coverage for all residents?
So the question is, with the terraces coming online in the coming months, basically what preparation we have made an assessment in terms of the staffing that we have and being able to continue to provide the quality of care at that increase of number of residents. I'm happy to say that back in 2021, we sat down with the Duke Physician Group, and they sat down with us. We all sat down together and assessed at that point what it would look like in terms of the physicians having the hours they needed on campus and our contract being expansive enough that they will be able to do their work for the residents that currently live here as well as the future residents. And we made those decisions at that point and went ahead and made those changes at that point. We revisited this yesterday with the Duke physicians and their administration as well as our administration, and we are still at an understanding and agreement that we are still in a good place. Those changes we made in 2021 have met that need. And please know the most important thing you need to know is that should something not be met in terms of service that maybe we didn't anticipate, we have the ability to go right upstairs and go with Anita and Karen and have a conversation, and the resident and their service is what's primary. So we can have those conversations and make those adjustments if necessary. I feel like we've pre-planned, we've been proactive in those decisions, and making sure that Dr. Little in her medical director role has the expansiveness that she needs to meet needs, as well as Holly and Dr. Boer as well, and Dr. Hanau. So that's the first question. The second question, I think, the way I'm seeing that, is that we are currently in our budget work time, and I have been in conversation with, and Anita has been in conversation with me in terms of the assessment of a third social worker, and what that looks like, what that role would look like, and how to best utilize that addition. No final decision's been made on that, but that is actively in the budgetary process for me, as well as communication with administration on that. So that's one of the assessments for sure. Each director has been asked to create their specific terrace's budget for understanding what that looks like in terms of care and service and housekeeping and dining and all of those things that happen, so that there is no interruption in service for anyone that is living here, and there's the service that's expected from the folks that will be residing in the new apartments. So I feel very comfortable, thank you for asking that question where that's concerned, and certainly if you have other questions about that, feel free, to ask me about that. But we are very much in that detail right now. Of course, having done much research and calculations and FTEs and all those things where that is concerned. Yes, ma'am. Well, that's what I was just saying. The current conversation is that we are looking toward adding a third social worker. 2 and then 1 additional one. Okay. Next question? Yes, ma'am. Right here in the front, Asha. That's okay. I can actually project my voice pretty well. Yes, ma'am. Right, so we have, prior to even putting this project, repeat the question, sorry. The question is there going to be any expansion of the number of beds we have in the health center, in assisted living or skilled nursing, based on the fact that we have 71 new apartments coming online? So one of the very base things that needs to happen when you consider building a project like this is you must do the actuarial study for your health center beds. We're responsible for doing that. At this time, our actuarial says, you have never been full in the health center. We've done the math for you. The transition of life that occurs has accommodated for the vacancies that are needed, and there's no need at this time to increase your number of beds. So we have to go with the math on that, and that's certainly what we did in advance of this project. Yes, ma'am, absolutely. I think I saw another question over here. Okay, thank you. Are there any other questions? Well, great. We really appreciate your time. We appreciate you being here. We will, yes, Dr. Little wanted to say something. Sure.
Just very quickly, I know this is part 3 of 4. For those of you who may not have seen part 2, we did go through quite a bit of detail in terms of the continuity of the medical services, what you would get at in the clinic and in the health center from the 4 of us, primarily the 3 of us being the main providers here. And so that's going to be available on Cubico. Again, we'll repeat it at a later time, but if you're interested in hearing that, that recording is available for you all and can be made available again in a very accessible manner. And then in the summer, you'll be getting some announcements about the three of us again are going to be doing a more in-depth discussion about cognitive impairment, some of the cognitive conditions and dementia, and how that looks through those transitions. If there are still remaining questions after hearing Jennifer speak about that today, we'll talk about it a little bit from the medical perspective as well.
So one of the goals of these groups is, of course, to reach residents, make them aware of how smart they were to sign up for a continuum of care, and what that means at the Forest at Duke. But the second part of that is to invite your family, invite your loved ones, invite people that are in your circle of support so that they can hear this too. Because if something gets complicated with you medically, what better to have your daughter who can share a bit about you, about this information with you, so that they can reassure you about that. They can share that with you, and this isn't the first time. You know, there's nothing harder than to call a family and say, this, XYZ situation has happened with your mom. I'm Leanne from the Forest at Duke, and they say, where is that, and what are you talking about? That happens. That happens. All I got was a forwarding note from my mother that said where her new address was. So please, please, please inform your loved ones and your family about what it is that you have been so enlightened to care for yourself and to have that support that you need. So we ask that we encourage you, share the links, share the recordings, do anything you possibly can to get folks hearing this information, because when it's an emergency, it's a little hard to hear. So I just wanted you to know that we are absolutely in support of making this connection with your families and with folks that are in your support circle. Okay? Yes, ma'am. So is that Cubico link available to the public, or is it private? I have no idea. I realize what
It
I said.
links to the
get some
YouTube
help.
channel. So you can share the link. It's a public link for YouTube that will take whoever it is directly to the video recording.
See, that's why April's here. I didn't know that. I knew you could, but I didn't know how to tell you. Okay. Thank you so much. Yes.
So we're going to work with Amari to get it in the news feed so that it'll be at the top for you. And then we'll probably nest it under the resources tab, but we're going to put it in the news feed so you see it. Okay?
Thank you so much for your time and attention. Enjoy your dinner.